Today we shall be talking about an important subject, especially in our part of the world and Egypt in particular, which is rheumatic fever. But before I start, I would like to thank all the frontline heroes and soldiers who've been fighting the COVID pandemic, especially in Egypt. And my heart goes out to the families of those who have given their ultimate sacrifice fighting this disease. Let me start with I plan to divide my talk into an introduction and definitions, epidemiology, some words on pathogenesis and pathology, clinical manifestations, diagnosis and the revised Jones criteria, guidelines on treatment and prevention. Let me start by introduction and some definitions. Rheumatic fever is a non-suppurative sequela to group A streptococcal pharyngeal infection. And therefore the epidemiology of rheumatic fever is that of group A streptococcal pharyngeal infection. Rheumatic fever and rheumatic heart disease affect children, adolescents, and adults in their most productive years. It is a disease of low and middle income countries and the indigenous populations of some of the high income countries. An example of that is the indigenous populations of Australia and New Zealand. This disease with its devastating complications of heart disease and death can be totally preventable. We'll talk about the epidemiology of rheumatic fever. Epidemiology itself is defined as the study of the distribution of a disease in a population and the factors that influence this distribution. Starting with the epidemiology of rheumatic fever and group A strep, I like to show this slide in most of my talks about rheumatic fever because it summarizes to a great extent a lot of the epidemiology and the targets of prevention. If we look back to 1862, before the Industrial Revolution, about 50 years before, rheumatic fever was very prevalent in Denmark, which today is considered one of the healthiest nations in the world. The prevalence or the incidence at that time was 200 per 100,000 people having rheumatic fever. Starting with the Industrial Revolution in the early 1900s, this incidence started to drop steadily until the 1960s. And even it started to drop before the introduction of penicillin. For a lot of reasons we see in these two pictures. After the introduction of penicillin, it continued to drop until it became negligible in the country of Denmark. If we look at those two pictures, you can see the difference between 1890 and 1911, starting with the Industrial Revolution. In 1890, you see the squalor, the filth that is present, the probably one-room house where everybody slept, maybe even animals were present at the same time, no sanitation, no clean water. This was the condition in those days. Starting with the Industrial Revolution, you can see sanitation has improved a great deal. People are more educated, more cultured. Sanitation is better, water is clean, and these differences are the ones that help bring down the incidence of rheumatic fever rather than the simple penicillin injection every month that we give for prevention, secondary prevention. It is estimated that there are around 300,000 to 500,000 new cases of rheumatic fever annually, globally. 60 to 70% will develop rheumatic heart disease. Close to 33.4 million people worldwide have rheumatic heart disease, and this is complicated by 230,000 deaths per year. All this can be prevented. It is so ironic that a rather innocuous sore throat should extract such a price from the host and the whole nation. If we look at these two maps, world maps, you can see that the prevalence of rheumatic heart disease was very high in the countries that are purple here, and Egypt is one of them, Algiers and Bolivia even in South America, where the prevalence was more than 10 per thousand population. That was in the 1970s and before. And we have a famous study called the Alub Heart Survey, which definitely showed this kind of prevalence. So it was a very rampant disease in Egypt, especially in the rural areas. In the 1990s, things improved a little. Egypt became in the red, where the prevalence was from 4 to 10 per thousand population. Rheumatic heart disease, I mean, was the prevalence was 4 to 10 per thousand population. And this shows some improvement. We were probably in the range of 7 to 8 per thousand in those days. This shows you how it was a problem until the end of the 90s. In 2005, shown on this slide, the WHO area of the Middle East showed a prevalence of 1 to 8 cases per thousand having rheumatic heart disease. In Egypt at that time, it was probably between 5 and 6 cases per thousand, although there are no real statistics coming out of our country to show this. But I know for a fact that things are improving. You can tell by the quality of education of the people. The people are more informed about this group A strep throat infections. They worry a lot about that. They go rushing to the doctor, and they even go up to doing tonsillectomy, which I don't think is required or is indicated at all. But this is what people are starting to come to understand, that sore throats cause rheumatic fever, which is a very important part of prevention. Now we come to the pathogenesis of this elusive disease. Early observations showed us some facts. With the development of auscultatory methods and the application of statistical studies, it became evident a century ago that chronic cardiac valvular disease was frequently preceded by acute arthritis. And another observation, certain contributing environmental factors have been suggested, and the fact that the classical disease presented by man has not been reproduced by inoculating them into the lower animals have caused most students to hesitate before considering the question settled. And this is actually what's happening today. 100 years of research and trying to find the real cause of the disease, and yet it still eludes us, and we do not have the final what you call missing links that we need, that may be sources of attacking and preventing the disease much easier than we do today. So let us start talking about the pathogenesis. This has remained an incompletely understood disease process for over 100 years, but definite progress has occurred in the recent past. Due to the complex cellular mechanisms, I have tried to summarize what is known in the next two slides. We can see here the group A strep adhesion and invasion of the pharyngeal mucosa or pharyngeal epithelium, followed by the antigen processing and presentation to B cells and T cells. This will cause changes and generation of cross-reactive B and T cells, which cross-react with tissues and parts of the heart, and this will cause the different manifestations of the disease, which attack the heart, the brain, the joints, and the skin. And of course, this is a very simple process, but it gives you how complex this situation is. Another one of the slides that I myself have developed, and this is the Streptococcus in the oropharynx, and it is, of course, the strep has rheumatogenic strains, so to speak. Class 1 or 2 strains are the ones involved. Virulence factors of these strains, there are lots of virulence factors that cause that microorganism to be very virulent to the pharyngeal mucosa. There are bacterial genetics involved, and tissue adherence is very important, of course. Then we come to the susceptible host. This is the first one was the microorganism, and then we come to the susceptible host, and that susceptibility may be related to genetics, maybe to a major histocompatibility antigens, or the non-major histocompatibility antigen, or it may be a polygenic type of susceptibility. And then we come to the B cells and T cells that I have mentioned, and the molecular mimicry between the produced antibodies and those affecting the tissues of the heart. And the B cells and T cells, of course, you have the killer T cells, and these may lead to carditis and chorea through the molecular mimicry with parts of the basal ganglia and the heart tissue, valvular tissue in particular. The next step is the acute rheumatic fever, which is a sort of an acute inflammatory response to the original strep throat, with cytokines, adhesion molecules, cytotoxic lymphocytes, and endothelial, and finally endothelial injury of the valves. This is a very simple thing, but it gives you the idea of how things can develop stepwise in a stepwise fashion. So let us recapitulate the Streptococcus first, the group A strep, the susceptible host, the molecular mimicry, and then the rheumatic fever or the injury of the different tissues, the heart mainly, chorea in the brain, the joints with arthritis, and the skin as subcutaneous nodules and erythema marginata. Now we come to a few words on pathology. The general pathology of acute rheumatic fever is kind of non-specific: fibrinoid degeneration of connective tissue, edema, and cell infiltrates. The specific pathology of the cells is the Aschoff nodule. It is a paravascular fibrinoid degeneration with Aschoff cells, lymphocytes, and fibroblasts. The cardiac pathology, as you know, is it's a pancarditis, endocarditis, which is the valvular pathology, and pericarditis. Myocarditis is controversial. The endocarditis mainly affects the valves. The commonest valve to be affected is the mitral, being subjected to the highest stress. The aortic valve comes next, followed by the tricuspid valve in the presence of pulmonary hypertension, and rarely the pulmonary valve is affected. It may be affected in cases, around 8% of cases in acute rheumatic fever. It is inflamed, but it does not lead to much problems in the future, because pulmonary stenosis is usually congenital. The tips of the valves are edematous with tiny platelet thrombi, and when healing takes place, fibrosis and contracture ensue, leading to the valve stenosis or regurgitation, as well as shortening of the chordae in cases of the mitral valve. Clinical manifestations of acute rheumatic fever has not changed much. Probably most of us know, but we shall just have a reminder. As we all know that acute rheumatic fever has major and minor manifestations. We'll start with the minor manifestations and other features that we may see. The minor manifestations include fever, which is usually above 38 degrees Celsius. In high-risk populations, it's about 38 degrees Celsius, equal to or more than 38. In the low-risk population, it can reach up to even more than 38.5 degrees Celsius. Arthralgia, elevated acute phase reactants, which include the sedimentation rate and the acute phase, the C-reactive protein, prolonged PR interval in the ECG, and this gives us an idea of the high normal of the PR interval at the different age groups. Other features that we may see in patients with acute rheumatic fever include pallor, epistaxis, abdominal pain, which are types of probably vasculitis, and pulmonary infiltrates. Pulmonary infiltrates in the olden days were considered like rheumatic pneumonia, were given the name rheumatic pneumonia, but it turned out that they are probably mostly pulmonary edema or localized pulmonary edema due to the severe hemodynamics of carditis and heart failure. The major manifestations of rheumatic fever are polyarthritis. It's the first arthritis in general, but polyarthritis is the one we are used to in high-risk populations. The large joints are the ones usually affected. It is a flitting type of polyarthritis. The joints are inflamed and swollen, and they leave no sequela. And they respond quickly to anti-inflammatories, which is one of the important diagnostic tools. If no response within 48 hours, consider a different diagnosis. That's how important the response is. Aseptic monoarthritis and polyarthritis are considered major criteria in high-risk populations, according to the latest revised Jones criteria. Carditis is the next commonest major criteria. This is mainly endocarditis and pericarditis. The endocarditis affects mainly the valves, and the mitral valve, as we have already said, is the most commonly valve affected. The mitral valvulitis causes a pathological mitral regurg and may cause a Carey-Coombs murmur, and when you hear that, you have a definite mitral valvulitis. The Carey-Coombs murmur is a murmur which comes and goes. It does not remain constantly, and it usually it arises from the edema of the leaflets, causing some stenosis. Aortic valvulitis will cause aortic incompetence. Myocarditis is a controversial issue, but the carditis, when it is present, there is tachycardia, which persists during sleep and is out of proportion to the fever. There is a rapid cardiac enlargement, gallop rhythm, and heart failure in some cases. And of course, pericarditis may have no pericardial effusion to moderate effusion, and a rub can be heard. Other manifestations, major manifestations, include chorea, which is Sydenham's chorea, and you all know about chorea. The late manifestation, it is a late manifestation because it does not occur with the rest of the major manifestations such as carditis and arthritis. It comes later. It is more in girls, and of course, as you know, subcutaneous nodules are important, and usually they denote a significant carditis, as well as erythema marginatum, which also denotes a severe carditis if present. Now we come to the diagnosis of acute rheumatic fever. The original Jones criteria in 1944 were divided into major and minor, as we have talked about clinically. The major criteria are carditis, arthritis, chorea, erythema marginatum, subcutaneous nodules. All these are healed and with no sequelae, except for the carditis, which can lead to the devastating valvular diseases. The minor manifestations are previous rheumatic fever, arthralgia, fever, raised erythrocyte sedimentation rate and later CRP, elevated white blood cell count, prolonged PR interval. These were the original Jones criteria in 1944. Required for the diagnosis of acute rheumatic fever were two major criteria, or one major and two minor, plus evidence of group A strep infection, which, as you know, is either an elevated anti-streptolizin O titer or a DNase B, elevated anti-DNase B. You may also have the presence of group A strep on throat culture or scarlet fever. All these are diagnostic of group A strep. The diagnosis was not as accurate as one would have hoped. There are quite a number of overdiagnosis and underdiagnosis cases and underdiagnosed cases. And of course, the overdiagnosed cases can eventually end in unnecessary penicillin injections every 3 to 4 weeks for 10 years or more. And the underdiagnosed cases may have repeat episodes of rheumatic fever, which lead to further valvular disease and premature death. So it was very important that the diagnosis improves with less false negatives and false positives. I'm not going to go through all the evolution of the diagnostic criteria of acute rheumatic fever since '92, but I just want to show you how it was that the doctors actually tried to find ways of diagnosing more accurately the process of acute rheumatic fever and in patients, because the Australian group have both the high-risk population and low-risk population in their country, and so they were able to make those criteria more accurate in diagnosis. The reason for that is that I'm going to talk about the final criteria of 2015, which will be coming in the next slide. And in this slide, you see the 2015 Jones criteria for the diagnosis of acute rheumatic fever. And you have the low-risk population and moderate to high-risk population with their definitions. So acute rheumatic fever incidence of equal to or more than 2 per 100,000 population school-age children, or all-age rheumatic heart disease prevalence of more than 1 per 1,000 population per year. This is a low-risk population. Anything less than 2 or less, 1 or less, will be a low-risk population. The moderate and high-risk population are children not clearly from the low-risk population. So we can see that the major criteria are pretty much the same in carditis. The clinical and subclinical carditis are both important in both risk populations. And as you know, subclinical carditis is diagnosed by echocardiography, and we are going to be dealing with that shortly. Arthritis, polyarthritis in the low-risk population has not changed. Monoarthritis, polyarthritis, and or polyarthralgia now are a major criteria in the high-risk population. The other major criteria are the same. The minor criteria are pretty much the same, except for in the arthralgia group, polyarthralgia is a minor criteria in the low-risk population, and monoarthralgia is a minor criteria in the high-risk population. Fever is equal to or more than 38.5 Celsius in the low risk and 38 degrees Celsius in the high risk population. The markers of inflammation, sedimentation rate is equal to or more than 60 millimeters per hour in the low risk population, and the CRP of equal to or more than 3 milligrams per deciliter, whereas in the moderate to high risk population you have a ESR of equal to or more than 30 millimeters per hour with the same CRP level. All this has to be present in the presence of a previous streptococcal infection, or the evidence of a previous streptococcal infection, which is either an increased or rising anti-streptolizin O titer or other streptococcal antibodies like anti-DNase B, a positive throat culture for group A beta hemolytic strep, a positive rapid group A streptococcal carbohydrate antigen test in a child whose clinical presentation suggests a high pretest probability of strep pharyngitis. Managing probable acute rheumatic fever. This is also an important topic. The probable acute rheumatic fever may be divided into uncertain acute rheumatic fever or highly suspected acute rheumatic fever. We'll start with the highly suspected acute rheumatic fever. You manage as if it is rheumatic fever. secondary prophylaxis for a minimum of 10 years or until age 21, whichever is longer, or until an alternative diagnosis is confirmed. And the doctor should review the child yearly, and echocardiograms for children 2 yearly and adults 3 yearly. A dental review has to be done yearly. As regards the uncertain acute rheumatic fever, secondary prophylaxis should go for 12 months or until an alternative diagnosis is confirmed. Then you reassess the patient. There is no change in diagnosis, still uncertain, the echocardiogram is normal, consider ceasing secondary prophylaxis. You change to diagnosis highly suspected or acute rheumatic fever, or it is confirmed, then you go as the highly suspected acute rheumatic fever, and then you can either change to diagnosis rheumatic changes on the echocardiogram. Then if you do have rheumatic changes on the echocardiogram or pathological changes in either the mitral or the aortic or both, then you review by a cardiac specialist, and the appropriate rheumatic heart disease care plan is undertaken. The echo criteria for clinical or subclinical rheumatic valvulitis, for pathological mitral or aortic regurg. These should be, all 4 criteria should be available, and in the mitral valve, you see it in 2 views. In at least one view, the jet length should be 2 centimeters. The peak velocity is equal to or more than 3 meters per second, and the pansystolic jet in at least one envelope. For the aortic valve, again, it's seen in 2 views. In at least one view, the jet length should be equal to or 1 centimeter. Peak velocity is equal to or more than 3 meters per second, and the pan-diastolic jet in at least one envelope. Now we come to the management of acute rheumatic. Medical treatment for acute rheumatic fever could be divided into the following: treating the group A strep from the pharynx and starting secondary prophylaxis, the symptomatic treatment of arthritis, manage carditis and or heart failure, manage chorea, and patient and family education should be started. The treatment of joint symptoms. Aspirin is the main and commonest medicine given. Some of the people, for young children, are afraid of the Ray's syndrome, which is a type of encephalopathy plus liver damage and can be fatal, and so newer non-steroidal anti-inflammatory drugs have been shown to be just as effective: ibuprofen in children and naproxen in adults. Paracetamol can be used for mild arthralgia. Meds should continue till all symptoms abate, because sometimes if you stop the meds before the medication, before all the symptoms are gone, you can get a rebound phenomena. So you continue your medicine until the symptoms are no more present, and this may take 1 to 2 weeks for most, but even longer for some patients. Treatment of carditis. Anti-inflammatory medications have not shown to alter the long-term complications of acute rheumatic fever, which is the rheumatic heart disease, valve affection. Corticosteroids possibly can be given with severe carditis. Treatment of heart failure when carditis is severe, which include bed rest, fluid restriction, and diuretics. Sometimes ACE inhibitors may help with severe aortic regurg, and valve surgery may be life-saving in some patients. Chorea resolves on its own in weeks to months. Rest and calm surrounding in most cases can be enough, but when it's severe, valproic acid or dipakine and carbamazepine or tegretol in severe cases can be used. Prevention of rheumatic fever, which is probably to me the most important topic of this talk, because as you will see, rheumatic fever can be totally preventable. The outline of prevention includes primordial prevention, which is dealing with the population at risk for acute rheumatic fever, and then followed that primary prevention, which is getting rid of the group A strep in the pharynx before it leads to the clinical rheumatic fever. Secondary prevention after acute rheumatic fever to prevent further attacks of rheumatic fever. Tertiary prevention is to deal with the already present rheumatic heart disease to avoid worse complications of heart failure and early death. Primordial prevention is to prevent the development of risk factors of a disease in a population. This is the definition of primordial prevention. In our case, it includes social, economic, and environmental factors to limit the spread of group A strep, and we will talk more about that shortly. Primary prevention is treating the group A strep, pharyngeal group A strep early and effectively to prevent the development of rheumatic fever, will also reduce colonization and the carriers of group A strep. Secondary prevention is giving regular antibiotic prophylaxis to prevent group A strep infection and hence recurrence in a patient with a history of rheumatic fever and/or rheumatic heart disease. Tertiary interventions are those with rheumatic heart disease to reduce symptoms, disability, and premature death. So, primordial prevention includes several factors which have to be done together. And as you know, the risk factor for rheumatic fever is group A strep, so we need to deal with this the risk factor in a way that will prevent the spread of this pharyngeal infection to children. And so you have better, less crowded, well-aerated homes, less crowded, well-aerated schools, checking for group A strep carriers in teachers, education of the population and primary health care givers, availability of good school health and primary health care facilities that reach all. Again, I like this slide because it shows the importance of primordial prevention, and you can see from those two pictures that in 1890 what the home looked like, in 1911 after the onset of the Industrial Revolution, what the home looked like and the people looked like, and that is what led to slowly decline of the incidence of rheumatic fever before the onset of penicillin in 1948. And so this is what we mean by primordial prevention. Primary prevention is treatment of group A strep pharyngitis before the onset of rheumatic fever, and that may be a benzathine penicillin G injection, one injection for the children who get rheumatic fever, and you can see here the weight and the dose that you need, and this is and for adults even 900 milligrams is fine, a deep intramuscular injection once. If intramuscular injection is not possible, then we have phenoxymethyl penicillin, which is oral. In children, 15 milligrams per kilogram up to 500 milligrams BID orally for 10 days. In adults, it's 500 milligrams BID for 10 days. If patients are hypersensitive to penicillin, then erythromycin ethyl succinate. Children, 20 milligrams per kilogram up to 800 milligrams BID. Adults, it's 800 milligrams BID for both its oral for 10 days. Secondary prevention is when a patient has already had rheumatic fever and we want to prevent further attacks of rheumatic fever, and this would definitely help making the valve disease much better than if patients keep on getting further attacks. The famous long-acting penicillin of 1,200,000 units is a deep intramuscular injection and is given in adults. In children who are less than 20 kilograms, they take half this dose. It is given 4 weekly or 3 weekly for certain groups. There are also oral ways to prevent, which are not as effective because adherence is not as clear and should be carefully monitored, and that is phenoxymethyl penicillin if intramuscular injection is not possible, and that's 250 milligrams orally twice daily for as long as we need to give prophylaxis. If there is penicillin allergy, erythromycin 250 milligrams orally, again twice daily for as long as we need to give prophylaxis, rheumatic fever prophylaxis. A commonly asked question is, how long do we give secondary prophylaxis? There are certain factors affecting that duration. The first one among them is the age. We know that acute rheumatic fever is less common between the ages of 25 and 40 and rare above 40. So this will help make the decision of the length of prophylaxis. The present severity of rheumatic heart disease and the presence of carditis during the initial episode, and all these increase the likelihood of further cardiac damage, and therefore we should probably give prophylaxis for a longer time. The time elapsed since the last episode, usually if 5 years have passed since the last episode, it is not common for a further episode to occur, so prophylaxis can be shortened. Socioeconomic standards, the background risk of group A strep, and the community, all these affect the length of prophylaxis. People coming from, say, advanced areas of a nation where healthcare is normal and you can shorten the length of prophylaxis. Whereas in very high risk populations where rheumatic fever is common, then you have to lengthen your prophylaxis. Adherence to treatment again is another factor. If you are adherent for a few years after the initial episode, this is probably better than if you're offered if you have poor adherence for many years. So if you have the first years after the initial episode, the secondary prophylaxis in that time is much more important than in the future. The assessment at time of cessation of the secondary prophylaxis, the evidence of moderate or greater rheumatic heart disease may warrant prolonged prophylaxis. Now we come to the duration of secondary prophylaxis, which is an important part of the treatment of prevention. And we will divide those according to the presence of and severity of rheumatic heart disease. In all persons with acute rheumatic fever or rheumatic heart disease, there is a minimum of 10 years after the most recent episode of acute rheumatic fever or until the age of 21 years, whichever is longer. So if a 10-year-old boy, for example, gets acute rheumatic fever, you're going to give him prophylaxis until he is 20 years old, and he gets no other attacks and he has no rheumatic heart disease, then he is doing well. After the initial episode has elapsed, and with follow-up, and you realize that you have patients with no rheumatic heart disease or mild rheumatic heart disease, then you can actually discontinue the prophylaxis after 10 years or up to the age of 21, whichever is longer. With moderate rheumatic heart disease, which is defined here, I will not go through them, you can read them, you continue until the age of 35. In severe rheumatic heart disease, and those who have had surgery, you continue until the age of 40 or longer, and sometimes for life. After going through this important topic of rheumatic fever, what's my take-home message? My take-home message is that rheumatic fever and rheumatic heart disease can be totally preventable, especially in our day and age. It requires the help of many facets of the government, the ministries of health and population, education, housing, information and other facilities should all sit together and find a way to talk about the things that we talked about during the primordial prevention. And you remember the slide of the poor house and the rich house. This is what these ministries have to sit down together and discuss and try to make a plan so we can avoid the spread of group A strep and therefore rheumatic fever and its devastating complication of rheumatic heart disease. Thank you very much.